You're listening to The Q Switch with your host, Spence.
Welcome, one and all, to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology, where we invite the innovators, thought leaders, and forward thinkers shaping the field of ophthalmology to discuss their unique perspectives. So let's jump right in. Today's episode, Human Vision, Artificial Intelligence, Finding the Right Balance in Eye Care, is one I've been genuinely looking forward to for quite some time, because few topics generate as much excitement and as much confusion as artificial intelligence in medicine. My guest today is Rehan Ahmed, a board-certified ophthalmologist and co-editor of AI in Eye Care, who also practices in Dallas, Texas at North Texas Eye Specialists, and has over 15 years of experience in comprehensive and surgical eye care. Dr. Ahmed's journey is truly remarkable, from early admission to medical school and full merit scholarship to training at Vanderbilt, Baylor College of Medicine, and University of Texas, to become a trusted voice in how AI can thoughtfully and responsibly be integrated into eye care. Beyond the clinic, Dr. Ahmed advises multiple eye care companies, serves on AI and member experiences committees at Texas Medical Association, teaches as an adjunct professor at UT Southwestern, and has become a national thought leader on AI through his writings, speaking, and his dedicated platform focused entirely on AI in eye care. Today, we're going to cut through the hype and get practical: what AI does well, where it falls short, how practices should approach it, and how to keep patients and staff at the center of it all. Dr. Ahmed, thanks for joining the Q-Switch Conversations. Welcome to the show.
David, it is a pleasure to be on the Q-Switch with you. Thank you so much for having me.
Let's go and jump right in. You've grown and developed into one of the nation's foremost authorities on AI technology, especially how it integrates into and impacts eye care. Where did this AI journey begin for you, and how does your passion and curiosity for this technology brought you to the place where you are today?
That's a funny story. So I was a senior in high school. This is back in 1999. It was I remember it vividly. It was New Year's Eve, 1999. I remember Y2K, and I was, instead of partying outside, I was a nerd. Let's just be honest, like most ophthalmologists. Instead of partying on I was programming. I taught myself C, and I was programming artificial neural networks. Back then, I was working with a university doing AI-related research on developing a vision system for a robot.
You're high school senior.
I was a high school senior.
Wow. Okay.
To learn to play tic-tac-toe. So I programmed this. It could identify an X and O, and we thought it was just the most amazing thing back then. The computing power just wasn't where what it needed to be, and so much to my parents' delight, because they did not want me to go to computer science. My dad is a doctor, and of course, that stays in the family. They were very happy that I said, you know what, I don't know where this AI is really going to be going. Let me just go to medical school instead. And there's not many decisions I regret, and I don't say I ever regret that one. David, if I did AI back then, I don't know, I may be in a different spot. So that's where the interest started. And then I worked in medical school on diabetic retinopathy screenings using AI, and I've just always been very tech forward. In medicine and ophthalmology, we have sort of the early adopters, and I'm an early adopter even when it comes to surgical modalities. Being in my practice, being the first to use. If a rep comes with the technology, I usually am the one who raises my hand, like, yeah, I'll try it. So that's
you're that guy in the practice.
I'm that guy. That's my personality with technology. I like to be a fast adopter and try things out, and so that's where it came from. And it's just been a wonderful journey, and I love all these technologies. And so fascinating.
So there's a gap between perception and reality. Where do you think AI is already delivering real value in ophthalmology today, not 5 years from now?
Yes, I think that is the fundamental question, because I think we have approached the end of the honeymoon phase of AI generally in society, and maybe ophthalmology. And when it first came out, ChatGPT, I thought it was a seminal moment. That's because your average person got to interact in an amazing way with this technology. And I think the past few years now, people are really wondering, are we in a bubble, right? Where is the hype cycle? And so, there's this classic Gardner's hype cycle where we're hyping and we're like going way down, and then where's the real value going to come? So I think your question is fantastic. I think it's here. It's still early days. So to be just very concrete, I think there's 3 buckets where AI can really play a role. We can go more into detail, but there's basically a diagnostics bucket, and that's where it's going to help us figure out diseases in ways that we can't really do. And there's a therapeutics bucket, taking care of patients through new pharmacologic interventions or new surgicals or new lasers, etc. And I think AI can help in profound ways in that. And then to answer your question, there's this last bucket where I think there's a lot of low-hanging fruit. It's the administrative bucket. And that's where today there are AI solutions that are right now helping doctors and clinics see patients and run their practices more efficiently. And I think, so for example, there is a technology that will do pre-authorizations for a clinic, and we use it in our clinic right now, where we get insurance pre-verification on every single patient who comes to our clinic. And this AI will call the insurance company on their own. It's an AI chatbot, talk to an insurance agent, and it'll identify itself. Let's say, hey, I'm Sam from, blank surgical center or blank practice. I'm calling to verify this patient's eligibility for their visit. Can you please give me, the approval code, and blah, blah, blah. They have a whole conversation. And the most hilarious thing, and I would love to have shown you a demo, is at the end, it says, what did you think of, what did you think of the conversation? And people's responses are so hilarious. They're like, it was just fine. And, because these voice bots are getting pretty darn good. I mean, in terms of their intonation, their just the way it sounds, the humanness and conversation. It's not perfect. It's not perfect yet, but it's getting pretty close. And so that's one way that clinics there are many other ways, but I think that's kind of a really, because that's a pain point that clinics are having. And that's a great way to automate it with an intelligent service.
I think the challenge with AI is going to be able to make people feel like they're dealing with a human, because I think that's what most patients want. They want to be dealing with somebody who's going to take care of them.
Yeah.
I think that still in our minds, robots are still robots.
Right.
It's being able to have that human interaction, even if you're not dealing with a human, at least feel like they are.
Right. Yeah. Yeah. So in a weird way, and this is counterintuitive and in a good way, the irony of AI is that it will actually improve the human-patient connection.
How so?
And the reason I say that is that if you think about it right now, if you're a patient in a clinic and you're talking to your ophthalmologist, oftentimes, although we don't want to admit it, it's this. And for those who can't see me, I'm looking, you're turning away. And everyone has this experience when you see the doctor. They're on their computer, they're typing while the patient's talking, and there's very little interaction. Or they come in really quickly, look at this, they look at you, and then they walk out the room, and you're like, what just happened, right? Because they have a million things to document. There's so much administrative burden right now on physicians and practices. So what will happen is that these AI systems, like the pre-authorization tool, is that it will free up time. It's because right now there's a human who has to do that, a laborious piece of time that you have to spend calling. Now you'll have that technician be able to spend more time with patients. Scribing is a very common example where there's so much time that we spend documenting all our findings. Well, it would be great, and there's already AI systems that do this, that will listen to the doctor and just say, hey, there's a 2+ NSC cataract, there's no retinal pathology, and we're going to talk about cataract surgery options or laser options, or etc. And the ambient scribe is just listening and is documenting. So then I'm, as a physician, looking straight at that patient, having a stronger human connection because of these AI systems. And so that's why I feel like it will actually improve that relationship, not make it worse.
Well, that does make sense now that you put it that way. That naturally leads to the other side of the coin. Where should AI absolutely not be used in eye care, at least with today's technology?
Yeah, I think that's a great question. I think there's human judgment in everything, in the decisions we make regarding actual treatment decisions. Just because an AI system says it recommends this glaucoma drop or this procedure or whatever, that doesn't necessarily mean that's right for that patient. You have to talk to the patient, their family members. There's all sorts of things that it can't replace. And so I think ultimately, instead of artificial intelligence, the term I like much better, and it's one that the committees I'm part of, such as the Texas Medical Association, the term that they propose is augmented intelligence.
Augmented
that
intelligence.
It augments the physician decision making, and so it's not. And I think for medicine, that's a great term, because it's human plus AI is greater than either of those systems alone. And so I think decision making when it comes to treatment, that's a place where right now, we want to be very careful until these systems really prove themselves.
When boundaries aren't clear, risks enters the conversation. What are the biggest risks clinically, ethically, or legal if AI is implemented too fast or without proper oversight?
Yeah. So I think there are a number of risks that we have to be cognizant of. I think one of the biggest risks that people think about is privacy. Where is this data going? Who's looking at it? Will it be identifiable data or not? If there's a scribe, like I mentioned, and there's some personal health information that's being discussed, I want to know that that data is secured and only going to the appropriate places, right? I think that's a non-negotiable. The other thing, and specific about AI systems, is bias. If you're having a diagnostic AI that's looking at a retinal photograph and being able to determine if there's diabetic retinopathy or not, and I'm happy to say with ophthalmology, we were the first specialty of medicine that had an AI approved for diagnostics.
Really?
And we already have a CPT code. It's 92229.
It's
for the autonomous detection of diabetic retinopathy. So
really,
you can go right now, and it's in tech. It's throughout the country, and several clinics have this. You're at a primary care doctor. It's like, hey, you have diabetes. You haven't had an eye check in a while. They'll take a picture of your eyes, and it'll tell you right then and there whether you have no diabetic retinopathy or referable diabetic. Then you need to see a follow-up, and that really helps with this. The number of patients who don't really need to be seen full eye exam by an optometrist and ophthalmologist, and so it's been that is a really fantastic system. But we have, in terms of risks, so that all that data had to be trained, and so we want to make sure it's representative data, and the FDA is responsible for making sure that these systems are both safe and effective, that they're going to do what they say they're going to do. And that starts with having really good data that spans, our country. So it's, from racial standpoint, socioeconomic, geographic, because a system that's trained only with eyes from, say, Alabama may not work in San Francisco, and vice versa. So we want to make sure that the data is geographically heterogeneous. And so the data is really important. And it doesn't miss anything. Another great example, at our podcast at ANI Care, we had Hunter Cherwick, who won the 2021 American Academy of Ophthalmology Humanitarian Award and works with Orbis on developing these systems. For example, and in terms of a global program, if there's an AI that looks at glaucoma, looking at patients' optic nerves, well, an optic nerve from someone from West Africa is going to be different than an optic nerve from someone from, say, Montana. And so these systems are going to have to be able to understand those nuances and differences. So I think bias and security for me are the things that I think about. Now, there's many other things, such as energy impact and cost and savings. But for me, in terms of thinking about an AI system, though security and bias are the number 1 and 2 things I think about.
Mm-hmm, mm-hmm. And risk isn't just about technology, it's about people. How do patients typically react when they learn AI is part of their care? And how should physicians frame the conversation to build trust rather than fear?
Yeah. And the laws are changing about this all the time. In fact, Texas just has a regulation that is now formalized and active that if there are any AI systems being used, you have to notify. I mean, it's common sense, but you have to notify the patient in advance. And so if there's an AI ambient scribe, meaning it's just kind of listening, there's a microphone that's just listening to you, you have to disclose that, of course, to the patient. And so I think that's going to be an important for safety and just to make sure things are aware, because people really care now. They well know that if something is being extracted, there's value there. And so that this is a little bit of the Wild West, but I hope as regulations sort of get more because I don't want to say they're antiquated right now, but we're kind of in early innings, and so we need to find out how things are going to go. And so I think the regulatory agencies are doing a good job of being on top of it. A lot more work to be done, but we're all going through this together.
So when you do, notify a patient and disclose that we're using an ambient scribe, how much pushback or like what are kind of some of the reactions you get? And has anyone ever said, no, I don't want that, turn it off?
No, I don't. I have not had that reaction. Now, granted, we're in early innings, so a lot of the stuff is outside of the patient view. So, like the administrative stuff, I think they like because it's getting to spend more time with the doctor. Now, once we get into the role, and maybe this is a couple of years out, where there's an AI-enabled robot that's maybe doing a procedure like cataract surgery. There's a company called Horizon Surgical Systems that's working on AI-enabled cataract surgery, where it's assisting the surgeon in doing the case. I think the framing of it really matters because at the end of the day, the doctor, the human, is still the one directing the AI. And so I think that's going to be an important thing. I have not so far seen any pushback, and I think people understand that AI plus human is better than either of those alone. Certainly, if I'm a patient and the doctor came to me and said, "Hey, I thought about this, but I also fed your information through an AI system that's secure and validated and trustworthy, and this is what I came up with regarding your diagnosis and treatment plan." Me as a patient, I would think that's fantastic. So I don't. So long as that's disclosed, I don't think patients will push back. I think that it just needs to be validated and shared openly with the patient. But we're going to see, that's my prediction for the future. David, what do you think? What do you think is going to happen?
Like you said, we're in the early days. I think now patients are probably a little more informed than they have been in years past. I think the uptake and acceptance of AI in the medical environment from a patient's perspective should be a pretty easy transition as far as I'm concerned. I think more so than anything, when I think folks associate AI and technology with adding efficiency as well as safety. So if you can spend any less time at the clinic, because you get in and typically in years past, you're looking at an hour wait time before you see the doctor, and then you're waiting in the little room, and you're there for a long time. It takes a big chunk of the day. Not to mention if you have a caregiver, which is many times the cases when we're dealing with patients who are getting cataract surgery and come see you. And so I think if you can narrow that time frame with which they're there, and when they're there, it's valued, and every moment means something, and AI can help again add those efficiencies and cut down that time at the clinic. I think that's going to be an added advantage, a sell, if you will, a point that patients will embrace and say, yeah, I want that. And again, it's how you deliver the message and how you unpack it for the patient. But if it's done properly, I think most patients would have no resistance and embrace it pretty quickly.
100%. We're using AI all the time in our self-driving car, Netflix, and telling what movie to watch next. So I think patients, like you said, are getting pretty wise up to that fact. And if it's helpful and beneficial and accretive in value, then there will be a higher chance for buy-in.
Yeah, I think there's going to be, much like I grew up before the internet, and so then you had, I guess, I'm not sure what generation it is, but they're like the digital natives. They grew up in a world with internet. Well, there will soon be a generation who are AI natives that they don't know the world without it. And so it probably comes sooner rather than later because the technology is moving so quickly. I think that it should be a pretty easy transition as long as it's handled responsibly and all the right decisions are made about it. And I think regulations is part of that as well.
Yeah, just to sort of tack on that point, I think it also improves access. Right now, we have an AI tool that afterwards your visit, it sort of goes through your visit, talks to you about it. One of the great features is that it's in different languages.
Yes.
So it's not just, it's Spanish, Vietnamese, Arabic, and you have an AI agent that will go, because, cataract surgery, laser surgeries, all the things we do with an ophthalmologist can be complex. And in a 15-minute visit, you're talking about 3 different multifocal IOLs, monofocal IOL, femto, non-femto. It is, if you are like, what just happened, and especially if you don't, and if it's not in your language. So that, I think AI has a tremendous ability to help slow things down, improve access, and deliver information in ways that patients want.
Of course, patients aren't the only ones impacted. How does AI change the daily experience of staff, and what determines whether it empowers them or alienates them?
Yeah. there's a, I think when AI systems come out, it's kind of like, is this going to replace me? And initially, staff and technicians, I think, thought that. Now surgeons think that too, and these AI robots are coming out. So I think everyone's sort of like looking over their shoulder. And the truth is, we don't know. I mean, but in the near term, I'm thinking 5-10 years, it will be highly accretive in value. It's not going to be AI is going to replace you. It may be the case that those who use AI will replace the ones who refuse or don't know how to use AI. So I think it's incumbent on everyone to sort of get facile with these technologies, and they're becoming so easy to use that it's really quite straightforward to do it. So in terms of staff, I think it's going to be very similar to the doctors and the technicians, right? Think about the patient journey. They come in, they check in, there's pre-authorizations that need to be done. All that sort of highly repetitive work will not need to be done anymore. Especially the stuff that doesn't require hands, right? So like a phone call, that could be done by an AI bot, and there can only be escalation when it needs to be done. So there'll still be humans needed, but only for the situations where the brain, that person's experience is really come to bear. And so even like the agent I talked about before in terms of the pre-authorizations, well, it can do everyone. It does 90%. But the 10%, it sort of gets stuck on, or there's some confusion, or there's a back and forth. And so the human in the loop, which is a phrase I love with these AI systems,
What's
is
the
going
phrase
to be a
again?
big part. Human in the loop. So you have an AI loop, but there's a human that's always part of it. So there's always a backstop for a human to come in and say, hey, what's going on? I don't know about you, but when I called my bank the other day, and I could tell it's an AI agent,
Mm-hmm.
and it wasn't a great one. And I'm like 000000000. You just want to get, you want to go straight to the human, right? Like, and there has to be zero buttons. There have to be zero buttons, right? We have to be able to, because it's not, it may get confused and it hallucinates, which is a term that means where the AI system is, from its data, it's just coming up with things that are total. It sounds right, but it's not right, and there needs to be a human in the loop to be there for when those things happen. So I think escalation is going to be a huge part.
When you talk about people thinking they're going to replace humans, you just mentioned that you either have or expect to be using ambient scribes. That was someone's job 10 years ago.
Yeah.
I mean, and so that's what I think people who in those roles at clinics and other, businesses around, that was someone's job. A human did that job, they're being replaced. And so how do you have that conversation? How do you make that decision? Obviously, financially, it's probably a positive one, because paying an AI who works 24/7 versus a human that works 8 to 5, needs breaks and all this kind of thing, there's advantages, but is it worth, some of the blowback? And are there limitations or blind spots in making that decision?
Yeah. Well, I think there are going to be differences in roles. So rather than just having a scribe, you're going to have a patient experience coordinator who does all the stuff to make that experience enjoyable, right? And you still may need someone to sit the patient down, to make sure they get in the chair right, to check their pressures, to look at their slit, to do a pre-exam. But instead of having someone just be a scribe, they're doing multiple elements of the patient visit. And so I like the idea of elevating roles to really interact with the various AIs. Now, it may be true that you may need fewer people. And that's something I think society is going to have to just grapple with. But the experience overall for the patient and the doctor and the practice may overall, certainly will be a better one.
This brings us to the practical question many listeners are asking. For a practice that's AI curious but cautious, what's the smartest first step to take?
Yeah, I get this question a ton. I'm on a WhatsApp group with a couple hundred ophthalmologists. And they're like, what can I do? I'm hearing all about this AI stuff, but not doing much. So where can I learn more or do more? So my first advice would be, hey, if they're not already using something like ChatGPT, Claude, or Gemini, which are the chatbots that are out there, that would be the first step, because I'm surprised and honestly a little shocked by how few people have actually interacted with that, especially, maybe someone mid to late career. in terms of actually using it in your clinic, right? So something I would say, hey, first step, start using this for your personal or professional, and maybe write some articles off it, and maybe try, hey, what do you think about its diagnostic ability? And you don't have to use ChatGPT. There's other ones like Open Evidence, which uses higher quality data. It's limited to like New England Journal of Medicine and Mayo Clinic, and ask it some clinical questions. See what you think it responds. One way I love to use it is, hey, can you write me an operative note on this procedure, right? Like if I'm in a clinic on a different computer and I don't have my tech, let's see how it does. So you just get familiarity with it. It doesn't mean you're copy and pasting into the EMR or things like that. Of course, do not upload any private health information or outside of HIPAA, but in ways that you could do where it's anonymized. I would say that is a first step for someone who's sort of AI curious and not doing it. After that, I think working through your EMR solutions, a number of EMRs, electronic medical records systems have AI enhancements where they'll have like an AI scribe that you can maybe try out, a pre-authorization tool like I mentioned. That would be a great place for these administrative type of things that I. And then the third, and not to plug our own journal, is the AI and Eye Care.com, and where we publish things for optometry, ophthalmology, and industry as a whole, where we talk about real tools that people can use. We have webcasts and podcasts and videos, real world solutions. And so I think getting curious, getting interested, talking to your friends, those are all fantastic ways to get started.
Not all AI vendors are created equal. What should ophthalmologists look for in AI vendors or platforms, and what are the red flags that should make them walk away?
Yeah. Great question. So I think and this I speak from personal experience. If I have many vendors that approach me, my first question is, who else are you working for, and can I talk to them? Getting references is really important. Two, I want to know, how do you secure your information? Not because I'm a security expert. Truthfully, I'm not a security expert, but I want to know that they have the proper certifications for them to be using a tool in my clinic, for example. And then I would also, want to know, what is the overall plan? Suppose I pilot your product, and I love to pilot things, so I don't have any upfront payments, or maybe something low to see if I like it and use it. And then what does a subscription look like anyway, after the fact? Because I want to make sure that either it's decreasing my OpEx, right? Or it's giving me some value that I can't find anywhere else, right? Like the scribe you mentioned. Well, how much, are you paying your scribe right now? How much is the AI scribe? What other things I'm going to need to do? And so I would love to have a trial period for these new technologies, because everything is so new, especially with these startups. They're excited to work with doctors, and so those are the three things I'd recommend.
Let's zoom out just a bit. How do you see the balance between AI as a clinical advisor versus AI making autonomous decisions, and where should that line stay firmly drawn?
Yes, there should be a firm line in that. Like I mentioned, in ophthalmology, it's a forefront. We're the first specialty that used Botox, the first specialty that used lasers, the first specialty that now used AI in healthcare in an autonomous way. And so there should be a firm line, and it should be highly regulated, because anytime you have an autonomous system, autonomous means that it's making decisions on its own. Like this diabetic retinopathy example, it needs to be clearly validated with the FDA, with lots of data to support that. And so I think any autonomous system has to go through a very rigorous process that has to be highly regulated. Now, I think that's clear. I think what becomes less clear, and I think where there's a lot of room, is the clinical decision support, where and there are many examples of this, many companies that do this, but like looking at an OCT, it'd be great if there's an easy button that you just click on the OCT system and it says, this is what the AI sees. This is where there's fluid. This is where you as a doctor, you spend a little bit more attention here, because this is different from the last month of the exam, right? So I think those systems would need less regulatory validation. I mean, still validation, but because there's an oversight from the doctor, it's supporting the doctor, and there's still a doctor looking at it. That's where I think there's a lot more latitude for systems to develop to help doctors, because you have that backstop of the physician looking at the information.
You spend a lot of time thinking about education. How should residency programs and medical schools be preparing young ophthalmologists for AI without replacing critical thinking that is bedrock in clinical decision making and in the OR?
Yeah, I think that's I think there's 2 points there. You drew in the OR at the end, so I think the OR, that's a different space, and I really love the capabilities for AI systems in terms of surgical training. There are all sorts of simulations that AI can be helpful with in providing novel types of approaches that you could do in the safety of a simulation, either using VR headsets or different types of really tactile feedback. So I'm really excited about that. I wish that was around when I was a resident in the OR. I think education more broadly within ophthalmology may need to be changed a little bit. We were required to memorize these like encyclopedias of information on various diagnoses. We had something called retina rounds, where the retina specialist would throw up a fundus photo, and then you have to go through a differential of 10 different things that could cause that. I don't know how I feel about that, because now you just need an AI system that will do it for you. But there's something lost if you say, well, we don't really need to do that anymore. Just have the AI system just do it. There's got to be a balance somewhere, and I think part of me thinks there should be a back to basics type of thing where you just still have to do it anyway, because sometimes you need to know that there's something out there that I should be then going to the AI system to look in a little bit more detail. And the truth is, the AI system can still hallucinate. And so I don't know the answer to that question. I think things need to change, maybe less emphasis on rote memorization, but still needs to be something. And I don't know if anyone's come up with a good solution yet. I just think we need to be very thoughtful about this moving forward. And we can't put our heads in the sand and say, nothing's going to change, because clearly things are.
Beyond training, from a practice management standpoint, where does AI truly improve efficiency or outcomes, and where is ROI still questionable?
So I think definitely in the administrative stuff, there's no question that it improves ROI. And the way you measure it, you could pre-select KPIs in the beginning of a pilot saying, this will reduce my FTEs by 1.5. And you just run a pilot. And I think, we have early data with our clinic that it's getting close to that. And I think some of the insurance verifications, administrative headaches are definitely showing that. Where it has not proved a clear ROI, I think, is honestly in the clinical decision support. We're still, it's still early, but I've had some colleagues say, hey, if I'm still looking at this, and if I'm still liable from a legal perspective, and if it's not, and if it just sort of helps me, and I still have to pay for that technology, but I don't get a higher reimbursement for using the system, I just have to do more of this type of exam in order to justify the cost. I think that's a harder sell. I think truly that's a harder sell. So they're going to have to be different, monetization plans on the part of the companies to encourage physicians to use those types of clinical decision support tools. Just because the reimbursement pathway isn't there yet.
I'm glad you went there, because once you start talking about ROI, the next question almost always follows: how does billing and reimbursement fit into AI-driven clinical activity today? And are there current CPT pathways that practices should understand? And where do you see reimbursement lagging behind innovation?
Yeah, that's the elephant in the room, David. And that's where the jury is still out. And I think I'm so supportive of innovation, but that's where things can grind to a halt. The diabetic retinopathy example is a good one, because there is a CPT code for that, for an AI autonomous reading. And so that sort of spurs a lot of innovation. Digital diagnostics was the first, and now there's several companies that have followed in that same pathway using that CPT code. There, however, as far as I know, there's no CPT code for clinical decision support or anything like that, or a scribe. So your ROI has to be from a decrease of your OpEx, right? You don't need a scribe, you don't need other things. And that's just much harder to prove. There's no billing support there. In terms of cataract surgery and the Horizon surgical systems, as far as I know, it's going to be an efficiency play, right? And that's where, and not to say that's not an appropriate way, and that you can drive and capture a lot of value with that. It's just, it may be a harder sell, because there's not just something you can click or a CPT code that you can use. And so that's where that is. But the good news for ophthalmologists is that the efficiency play is a huge part of it. There are not enough ophthalmologists in the country to do all the things we need to do. So if there's a laser that works better, if there's a diagnostic machine that works better, if there's a clinical decision support that allows you to see more patients or maybe offload some of that to other professional, maybe an optometrist or something, that is huge. That's not a small number, but it's just different. It's not GPT.
With rapid expansion comes responsibility. If you had to outline a short AI best practices checklist for eye care practices, what would be on it?
So I think the number one is get in the water. It's fine. It's nice and warm. If you're not using AI systems, you know that it's coming, and start trialing new technologies. Like I mentioned, the ChatGPT, the Geminis, the Claudes of the world. Start using those technologies. That'd be number one on my checklist. And that's really for the practice owner to be doing. This is not something that, you're going to hire a consulting agency and they're going to come in and AIify your practice. You're going to have to know about this. This is going to be a big part of what's happening. So that would be number one. Number two is it's all about solving problems. So I would look at your clinic, at your workflow and say, hey, where are one or two of the biggest pain points that I have? Is it back end? Is it billing? Is it appointment scheduling? Is it pre-authorizations? Is it some of the technology? Is it clinical decision support? Identify one or two max of the problems you have, and then start looking and ask ChatGPT, what are the AI solutions for that? And then see what's around. And you're going to find that there are going to be plenty of solutions because the problems you have as a practice owner are problems that other people have. And there have been solutions that are being worked on right now. Personally, I think the administrative stuff is the lowest hanging fruit. And that's where I recommend people to go, because that's not directly interacting with patient care. It's something that could be easily measured. And it's a place where you could easily identify some key performance indicators and see if this is something you want to pursue.
Yeah, I think from an owner's perspective, that back-end AI integration adds efficiency, cost savings, again, has nothing to do with patient interaction, patient facing, but in the overall functionality and operation of the practice, it's, certainly a positive move to start integrating some of these technologies for those facts alone. Let's talk about the future, but stay grounded in reality. What upcoming AI developments in AI care genuinely excite you and why?
So I think the looming crush in eye care in this country is the number of cataracts that really need to be done. This is the US and more importantly, worldwide.
Mm-hmm.
So looking forward, if I were to put on my sort of future cap, but still grounded in reality, because these systems are right now are real. AI guided robots to perform the majority of cataract surgery.
Whoa.
Cataract surgery it's highly visible, it's highly mechanized, it's highly procedural in terms of the steps that need to be done. And systems have proven from main incision to IOL insertion and viscoelastic removal that it could perform the majority or all of the steps. And so
really,
I think this
can happen now.
This can happen now. It's still in testing. It's still in testing. But looking forward, I think, and initially it'll be, and maybe always there'll be a surgeon right there. But think about the Da Vinci surgical robots that are being used right now. I think this is an extension of that. And I think this could be applied to other procedures we do that are just being crushed by the numbers of patients, like diabetic retinopathy or glaucoma. So that's what, looking forward, I think, because I think I started this conversation talking about the three buckets of diagnostics and administrative buckets of AI. We spent a lot of time on those, but looking forward, I am super excited about the therapeutics, because at the end of the day, we're about treating patients and improving their lives. And so I'm excited about the possibility of two of the biggest things, like cataract surgery and diabetic retinopathy and plus glaucoma. Those are all huge numbers, and we need the help.
Finally, a bit of perspective. If a colleague says AI is just another trend that will fade, how would you respond?
We shall see. I am of the opinion that AI will be so fundamental to and I hope there's not hyperbole, but our species. Looking back, we're going to be looking at this time, and hopefully with awe and like all the changes that came out of it. I'm an optimist at the end of the day. To say it's a fad like phacoemulsification, I'm not saying that that's a fad, but it's like one piece of technology. But it impacts. I've never seen something that impacts one just everything from patient intake to surgery. I mean, we talked about everything, the entire patient journey we talked about today. So I've never seen a technology, especially when we're talking about healthcare, ophthalmology, or eye care in general, that's touching everything. So I don't see it as a fad. I see it as a foundational technology, and certainly there's enough investment right now that's supporting that viewpoint. So I would disagree with that view that it's a fad, and I'd ask them if they felt that way to try it out and tell me what you really think, because I've not met anyone who's really tried out these technologies who has just not been sort of awe-inspired with some of the stuff that it comes up back with.
Sage advice from somebody who knows what they're talking about. So, Dr. Ahmed, This has been an incredibly thoughtful and practical conversation, exactly what this topic needs. Before we wrap up, I'll give you the floor. What's the best way for listeners to connect with you to learn more about your work, your practice, and your ongoing efforts within AI and eye care? And where can they connect with you and learn more? Plug some of those things so that they can keep the conversation going.
Thanks for the time, Dave. This has been a wonderful conversation. For those who are interested, please follow AI in Eye Care. That's AIinEyeCare.com, all one word. They can email me at Rehan, REHAN, at AIinEyeCare.ai. I encourage you all to follow our publication on LinkedIn and wherever you get podcasts. We publish a ton. We just had Uday Devgan was on our podcast, Rania Habash, Hunter Truitt.
Wow, I know both those folks. That's high powered, man.
We we're talking all about what's new and upcoming in AI. So for those who are interested, please give us a visit, send us an email, and looking forward to connecting with your audience.
Awesome. Well, once again, thanks again, Dr. Ahmed, your time, your insight, and for helping bring clarity to a topic that will shape ophthalmology for decades to come. To my dedicated audience, the Q-Switch Conversations podcast is my way of giving back to an eye care industry and community that shaped my career, my perspective, and my passion for what we do. This platform is truly built for you, the clinicians, innovators, and change makers, redefining what's possible in our field. So if you've got a fresh perspective, a unique experience, or know someone doing great things in eye care, I'd love to feature them on the show. You can hit me up on LinkedIn or drop me a line at d.spence@meridian.ch. And as always, we'd like to thank Riverside FM and Passionate Media for making this show happen, and our benefactors, Meridian Medical, for making it all possible. That's a wrap for this episode of the Q-Switch Conversations podcast. Until next time, I'm Spence, and I am out.
You're listening to The Q-Switch with your host, Spence.